Thank you, sir, for giving me this opportunity once again. So this year, I am going to just add up our experience of last year to the previous presentations. And this year, the one thing which changed was the 3 surgeons has changed into 6 surgeons now in our center. So the last year, our experience will be a mixture of little bit experienced surgeons experience as well as the newly started surgeons experience. And the one thing what I changed a little bit in the manual dissection was this from what I learned from Dr. Bassett. The initial single stroke which he taught me, I changed it into a little bit longer section and also gradually increasing the depth and using micro crescent to start the dissection at the periphery first with the air bubble guidance, and then I used to lift it a little bit and see how deep I have gone. So if necessary, I change the depth of dissection accordingly. So this helps me to get more predictable donor flap depth thickness. And donor insertion, of course, I use the same technique still, the viscoglide, like I use a lot of sodium hyaluronate, and then over which I place the graft unfolded with endothelium down and just push it in. And I feel I'm very comfortable with this method. And coming to the results, of course, our indications gradually is changing. For fugues, almost 100% now we go for DSEC, and for even pseudophakic bullous keratopathy, according to the anterior segment, most of the cases we do the DSEC. But more and more regrafts also now we are slowly converting to DSEC, and gradually we started on the CHED and ICE also in few cases, but not with much experience, very few cases. And coming to the results, like depends on the preoperative status of the eye also. So the up to more than 618 we could achieve only in 40% of the cases. Of course, the previously unviolated eyes like fugues, we could get very good results. And the failure rate about 14%, and of which 6.2 was primary failure and late failure was 8.5%. And the primary failure, again, if you see the graph, gradually with experience it's coming down for us. And the last year it was a little bit more than the previous year. As I told, more new surgeons joined the team now. Naturally you can expect, but still it is well within the range. And when we compared it with the donor factors as well as the recipient factors, we couldn't find any correlation in the primary failure. I think it's mostly of surgeon related problem. But coming to rebubbling, it's a little bit different story. The rebubbling, you can see in between the 2011 and 12, our rate was really high, because that's when we started doing more complicated cases like FATIC and other, combined with other SFIOL and other procedures also. And now again that is also settling down. And but rebubbling is influenced by the recipient eye anterior segment as well as the preoperative count also. And also rebubbling is the main reason for graft failure, late graft failure also in our cases. And the astigmatism part, again in regrafts and other previously violated eyes, as we expect it will be more, but in fugues we could get less than 2 diopter cylinder in 78% of the eyes. And thickness of the graft, again manual dissection you will be wondering. So if the graft is going to be very thick, you have more hyperopic shift, but in our range spherical equivalent is about +1 to -3. And the endothelial count also, as I told, more of our corneas preoperative endothelial donor corneal count was 2200 to 2500, because in our scenario we can't just wait for above 3000 cells and all. So considering this, our endothelial cell loss is still well within the range. And some of the pearls what I learned in CHED, of course, as already many times repeated, we have to see the preoperative thickness and accordingly we have to decide. But somehow these eyes can behave very bizarre way. As we can see in one patient, the graft started after initial a week or two clear graft, it started becoming white, and also the edges started curling in. We don't know the reason, and finally we have decided to go for a PKP for that patient later. But in a primary failure, in a otherwise normal eye, otherwise good non-inflamed eye, we have done even DSEC and we could get good results. And we had one immune rejection also, but again it recovered very well. And some of the cases with good follow-up, about 1 year follow-up in a PBK, the cylinder is about 2 and vision improved to 636 with endothelial cell loss stabilized at 44%. And follow-up Fuchs case with 2 diopter cylinder, vision improved to 612 with 43% cell loss even after 2 years. And this is a case with 4-year follow-up where the endothelial cell loss stabilizes at 51%, I mean till 51% only now, with a very good visual recovery from FCF to 6.9. And you can see in the OpScan that the cylinder what you get after DSEC is more regular astigmatism compared to the PKP astigmatisms. And this is another thing, you can, this is a big giant bulle so with fibrosis where the blood seep into the undersurface. So this case was actually planned and put for PKP, thinking it's a big scar. But then on this table when I could remove the thing, you can see the crystal clear stroma there. So still you can plan and go for a DSEC. So we can decide on the table. And some of the regrafts, like when you can boldly go ahead with DSEC in regrafts also, if the graft is well centered and the preoperative astigmatism is less. But if it is an off-center graft or astigmatism is more, better to go for a PKP, re-PKP. And even in post-TKP, we have done quite a number of DSECs. And even a post-therapeutic DALK, in one case of acanthamoeba keratitis, after the TKP, I mean therapeutic DALK, you can see still the endothelium is not so good with a lot of endothelial pigments and a cataract. So when I have decided to go for a cataract dissection, cataract surgery, I have gone for a DSEC. I thought like let me give it a try, otherwise later we can convert. So far the patient is holding good, and with a 3-cylinder she is getting about 618 vision. So even in a DALK we can try this, but of course you can see a double thick interface in the OCT. Whenever we have, regarding the IOL, whenever it's a phakic patient, better to combine with a IOL implantation. And if the IOL is unstable, better to go for a stabilized fixation like SFIOL. And in a phakic IOL, I removed the IOL and I didn't replace anything. This is not a patient for another IOL implantation. And if the graft is too small, you can end up with a peripheral bulle. That also we have to keep in mind. And coming to the, I mean last year also I mentioned this point, in cases regrafts you have to go for a smaller endothelial scoring as well as smaller graft. And also if you open the previous wound, better to put a pre-placed suture before reforming the AC. And also sometimes the endothelial removal scoring will be very difficult and you can leave it like that itself, endo on, we can do the DSEC. And this is another thing what last time also I have told. I don't do any venting incision or roughening or anything. I just, when we are waiting for the air, with the air for 10 minutes, I used to apply glycerin on the top of cornea every 2 minutes like that for the 10 minutes. By the time the stroma will get nicely desiccated and the graft will adhere very nicely. And with this technique, I mean almost I never had any need to go for any rebubbling. Thank you.